Yeah, hi. So I will share, just so that everyone knows, as soon as I share the screen, I'm going to lose the ability to see everybody. So what I will need people to do is probably just to speak up if they want to answer anything or ask a question. I'm going to go to the share. Okay, so I'm hopeful that everyone can see that presentation slide, which is off Mentimeter. And with that in mind, could you just go to menti.com? So just type into your smartphone or tablet or computer, whatever, just www.menti.com. And then if you go to that code, it'll allow us to be a little more interactive. Is that okay? Okay. So when Ash asked me to do some EM cases, I had a little think about what that might look like from a foundation doctor's point of view, and it could be limitless. So what I thought I would do is just cover maybe some slightly more challenging things and get people thinking about when it's helpful to use tests or not in an emergency department, which is what we do quite a lot of the time. When patients come to us, they don't come to us with a disease, they come to us with the probability of a disease. So first and foremost, a nurse comes up to you and hands you this ECG and says, "Doctor, can you look at this ECG?" This is a 44-year-old lady with known alcohol dependence who's presented with 48 hours of vomiting. So if you could shout out, first of all, is that normal or abnormal? And anything that you can spot on it that's worrying.
So there's nothing in the chat box so far.
Anybody? Beulah? Anyone?
Yeah.
If those trainees are on ST depression, yeah. TWI, I can see that on the chat, not quite sure what that means. Okay.
T-wave inversion, I guess.
Oh, right, yeah, love a little three-letter abbreviation. Okay. So first and foremost, we've identified there's a couple of abnormalities. So what I'm going to ask you is first little interactive question is, first one that comes up on your Menti code, which electrolyte do you need to urgently check? Great. It's a little bit like ask the audience, isn't it, when you do Who Wants to Be a Millionaire? So I think everyone's in conclusion that the potassium is what we need to check. Yeah. Given the history of vomiting and also those ECG changes that you can see, you've got to suspect the potassium is going to be low. So on this lady's has a quick venous blood gas. She's got a potassium of 1.8. So next steps would appropriately be probably cannulating it and getting some formal blood tests and seeing what's going on. In terms of treatment, this is a lady with vomiting and she's alcohol dependent. So if I could ask you just to pop into the chat box as well, what other treatment do you think she needs to have promptly administered in the emergency department other than correcting the potassium?
Nothing so far.
No, it's okay. I'm just flicking between screens to try and check. Pabrinex, great.
Pabrinex, yeah.
Yeah. You might also add potentially some chlordiazepam epoxide or IV benzodiazepine, depending on whether this lady starts to go into withdrawal. So she's a really high risk of withdrawing from alcohol related to the vomiting. I need to anticipate for that. Okay. So next little question then on this. There were some features on that initial ECG that were abnormal. Someone mentioned T-wave inversion and some ST depression. So which of these would you not expect to see with hypokalemia? guess there's more indecisiveness here. We had 9 responses before, we're down to 3. Not sure what that says. 5, great. So again, majority of people agree that it's peak T waves, which we'd expect to see on something with hyperkalemia. So typically with hypokalemia, you will get T wave inversion, ST depression, and you definitely get a long QT interval. But you might have come across the term of a U wave. And this is what this ECG is supposed to show, where you start to get a little wave beyond the QT, which would be a U wave, which can be indicative of hypokalemia and a few other things. So the last question for bonus points: in which of the following cases would you not expect to see U waves? Now, you may or may not know this. This is really testing some knowledge. And we'll see if there's some variation on this then. Yeah, definitely some going across the board, aren't they, answers? Okay, so the correct answer for this is hypernatremia. So U waves are commonly seen in digoxin toxicity, where you get prolongation again of the QT interval, and it can present with vomiting. So it's worthwhile checking the drug history for people like this. And in the context of low potassium, I'm pretty sure that you also get a low magnesium at the same time. So you might need to also think about replacing both. So you will see it across those, but not in hypernatremia. If someone's persistently vomiting, you might get hypernatremia, but it's unlikely because you tend to lose salts for both. So yeah, great. Right. Another quick case for you then. So we have fairly common situation as a 47-year-old lady who presents with sudden stabbing, non-radiating, 10 out of 10 worst ever epigastric pain. She's had some episodes before, but never as bad. She's opened her bowel, she's passed flatus. She's previously had a hysterectomy. She's got known gastritis, and she's previously had small bowel obstruction, which has been managed conservatively. She's been examined. She's got soft but tender epigastric area. She's got bowel sounds. And in terms of those generalized observations, I think we would agree they'd be fairly normal. News-wise, probably score a 1 for the slightly lower heart rate. She's prescribed IV morphine and fluids from assessment, which again is pretty common from an ED point of view, managing the symptoms. So this is pick as many as you would like. Which investigations would you consider doing on this lady at presentation? I'm not going to ask you the why, just the which. Okay, great. So across the board, most people are going for the sort of abdo things, doing amylase, LFTs, and a venous gas, fairly reasonable. Now, about 50% of you would only do the troponin, and some would do the ECG, and a few would do the plain abdo film. So in terms of checking things, if her pain onset had been 2 hours ago, you can pop it into the chat box. Would the troponin be relevant at that point? In my rhetorical question answering. Four-hour troponins. So you definitely need to time the troponins, don't you, from the onset of the pain afterwards. We say either at least 3 hours from the onset or 3 hours after they arrive in the ED, if you're not sure which is more accurate. Doing an ECG on arrival, I think, is really relevant. She's slightly bradycardic, this lady, at 55, you'll remember from her OBS. And it would be helpful to know that there wasn't some degree of ischemia, because Dr. Thacker, as in Dr. Ash Thacker, will correct me on this, but I think around 30% of people who present with an acute MI will present with gastrointestinal symptoms and present in a typical fashion, particularly women. So I think an ECG is a definite, and I think a troponin needs to be timed at the right time, but I would do one. In terms of her amylase, again, and LFTs, you could be misled by those in that your amylase will only peak at 24 hours. So in terms of choosing an enzyme, a lipase is far more reliable in the acute phase of a possible pancreatitis. Okay. And then the abdominal x-ray, a venous gas, I think is very reasonable. If someone's got 10 out of 10 pain, you want to know what the lactate is. So plain abdo film. So again, I'm going to open this up to the chat. Does anyone know in actual fact how sensitive an abdominal x-ray is when you're concerned about obstruction? I'm hopeful most of you will have done a surgical job by this point. Not very sensitive at all. Good, like that. That's a vague. Yeah, thanks, Megan. But I agree, it's not particularly sensitive. Does anyone want to put a figure on it? I can't tempt anyone to a figure, can I? A guess, a wild guess, 10%. Wild guess, Emily. It's a little bit higher than that. About 50% sensitivity will show up bowel obstruction. The question is, are we very good at interpreting x-rays as clinicians? Depends if you do it all the time. Often you find that you'll get a degree of air within the small bowel, but it won't have approached over the 3 centimetre distension, and you're not certain. So of those 50%, about 20% of those are misleading, and it's really, really difficult to be able to assess. In the same way that I didn't put erect chest x-ray on that list of questions or possible investigations, I think doing an erect chest x-ray would have its place. But again, it's only 70% sensitive, and this is sensitivity of picking up an abnormality, of showing free air. Of course, once you get free air under the diaphragm, you've got a mortality rate of 40% at any age. So a perforation on plain film is probably something you don't want to see. And yet our surgeons ask for these things all the time. Okay, I may be labouring a point here, but use your clinical judgment. So investigations wise, okay, let's move on a slide. This is one of those where it's a word cloud. I want you at this point, you're doing your investigations, there's 10 out of 10 epigastric pain. Just give me your top 3 differentials. Let's see what people come up with. This is before we have any results. Pancreatitis, I've got that so far. Oh, ulcers. Acute aortic syndromes, okay. I'm assuming you mean like a potentially ruptured aneurysm. MYHT. It's because I said 30% of people present with gastro symptoms. You think I'm leading you down that line. Okay. Any more for any more? Depends how fast you type, I suppose. So got pancreatitis, mostly. That's the biggest word so far. Gastroenteritis. Tend not to cause pain. I think that's one of the things I would say is D&V type symptoms tend to cause D&V. You get the pain after you've been vomiting a lot, but on this occasion it was just pain. Okay. So differentials in my book are, this could be a pancreatitis, agreed. It could be a cholecystitis. She's previously had small bowel obstruction, this lady, so it can't be ruled out. And it could be an acute coronary syndrome if you use that umbrella or an MI. Right, these are her results. So her plain abdominal x-ray with its sensitivity of 50% looks normal. Her LFTs, her amylase, which peaks at 24 hours, is normal. Her troponin and ECG are normal, and her lactate is 4.8, which I think we all agree is high. So now, what is your likeliest diagnosis? Okay, so majority, everybody has decided that this is now a small bowel obstruction, even though there is a plain abdominal x-ray which is normal and some liver and amylase function and amylase ECG. The only abnormality you've got is a lactate. So how or why can you sell that to a surgeon as a small bowel obstruction? I'm happy for people to unmute and talk, or you could type in the chat. But I want you to think, you're working in an emergency department as a foundation doctor. How do you persuade the surgical reg that this is definitely an obstruction? What are the features? There's a deathly silence on both. A minute. Severity of pain, lactate could indicate, yeah. Yeah, I agree. So Megan's saying severity of the pain and the previous history of small bowel obstruction, normal investigations. Previous surgery. Yeah, absolutely. Adhesions are definitely the commonest cause of small bowel obstruction. And the lactate implies some ischemia. Good. So I think we all agree that the key thing is here, the lactate. A lactate of 4.8 in an otherwise fit and healthy individual is exceptionally high. 10 out of 10 pain is something that you should not ignore. And if someone has been given morphine intravenously for their pain, what I want you to take away from this, if nothing else, is that person is not suitable to be discharged from an emergency department and should be kept for an assessment of some kind and a consideration of further investigation. The other take home that I want you to have from this is if you perform these investigations whilst the amylase is normal and the troponin and the ECG may be normal, you've got to put the appropriate chronology on those, and you've got to understand what your test does. So an amylase at probably less than 24 hours, certainly less than 12 hours of onset of the pain, may be entirely normal even in acute pancreatitis. And similarly, if you take your troponin too early, it may appear normal, which is why we repeat them. Or if you have it entirely negative, go back and check the onset of the pain. So those are my take homes from this case, but great. So this lady had a CT abdomen, which shows small bowel obstruction related to an intestinal hernia, which is not uncommon, but her initial plain films were completely normal. So great. Okay. Or someone popped sepsis. I've noted that. No. I think we get a little bit obsessed that lactate is one of the markers that we need to check in sepsis. Think sepsis if someone looks unwell, if their new score is high, agreed. But they may not look unwell, and then you've got a question, just because the lactate's high, there are plenty of other causes of a raised lactate. So please don't forget ischemia. Okay. So our last little nugget, again, is this lady. So she's a 70-year-old lady, presents with non-traumatic calf pain and swelling for 24 hours. Pain's gradual, but getting worse, and she cannot walk. She's previously had multiple PEs and DVTs with a strong family of coagulopathies. She's on rivaroxaban, which is one of the NOACs, and amlodipine for high blood pressure, and she has an IVC filter in situ. Rare, but possible. She's pretty independent, so a frailty score of 2 means you do a bit more than walking. So she plays golf, let's say, once or twice a week. Cardiovascular parameters, other than slight hypertension, I think we'd agree are normal. And on examination, her calf is exquisitely tender to touch. The skin is firm to touch but intact, has a normal colour and temperature. She's got good pulses and a good cat refill time. Sensation is normal. Now, the Achilles tendon is difficult to assess because of pain, but seems intact. But the pain is exacerbated by passive stretch. And the examination above and below is normal. Never forget those bits. Okay, so she has some routine bloods, which is a D-dimer, a full blood count, a clotting screen, creatinine kinase, and her lactate. What's the next thing you're going to do? What is your next management step? Got 4 so far. I think there'll be still some people having a little think about this. Yeah. Okay. So it appears that the majority are going for a compression ultrasound of the lower leg. Okay. So this lady's taken her medication appropriately, has no gaps in her medical history in terms of taking it at the right time, right day. So she's on a rivaroxaban and she's got an IVC filter in situ. In terms of having a further blood clot, the probability of that is entirely remote. And this is the point where you need to stop and think, is this a test I actually need to order, or do I need to do something? So the correct answer would be to elevate the limb and give some pain relief, because she's sore and it's making a full assessment difficult. And you might also reduce some of the swelling by elevating the leg. Okay. You then need to really think about your Wells score. So I want you guys to calculate this lady's Wells score. You can try and remember it. It's the right side that's painful. So it is 3 centimeters larger. She doesn't have any pain along her deep veins. She doesn't have pitting edema. She doesn't have distension of the superficial veins. She's not had any recent surgery, immobility, nor is on treatment for cancer. She's previously had a DVT. So if you can do, and in the next minute, try and calculate the Wells score, and you can plug that in onto Menti. Let's see how reliable our Wells scoring is. I guess people are probably frantically looking at MD Calc to work out what the Wells score is. 2. Someone's gone for 2. A few people going for a 2. Okay. So it looks again like the majority of people are going for a 2. So you will get a positive 1 point for having calf circumference of 3 centimeters or greater. And you get 1 point for having a previously documented DVT. But for those that are scored a 2, what about the alternative diagnosis to a DVT as likely or more likely? Or have you expanded your horizons to really think, is this actually a DVT? Because at which point you think, well, there could be something else going on, and the chances of having a further DVT are pretty remote, then a Wells score would probably be a 0. Okay. So all of her blood tests are normal, and she's being given IV paracetamol and 10 milligrams of Oromorph, but her pain score is 7 out of 10. So what is her likely diagnosis? Whilst you do that, I'm just going to go and shut my door. Great. So the important thing to recognise here is that she's been given pretty decent analgesia, hasn't she, in the form of IV paracetamol and Oromorph, and she's still got a pain score of 7 out of 10, and she can't weight bear. So what you've got here is pain which is disproportionate to the clinical findings, and remember she had pain on passive stretch, both of which are signs of potential compartment syndrome. In terms of developing compartment syndrome, it can happen with non-traumatic acute bleeding related to any of the anticoagulants, whether that's warfarin, we would commonly seen in the past, or the novel oral anticoagulants. So it can just be bleeding into the calf compartments. And within the posterior calf, which is where she's tender, you've got two compartments. One is deeper than the other. And if you get a compartment syndrome or acute bleeding in the one that the deeper of the sort of gastrocnemius area, then it can go unnoticed. You wouldn't necessarily see bruising within the skin either. So if someone presents with pain where it's swollen and they cannot weight bear, then you have to assume that there is something going on underneath that, and don't assume it's just because it's a leg pain, a DVT. Thank you. That is the end of my talk, and I'm gonna hopefully, have I brought you back? Have I stopped sharing the screen? I'm not sure, but hopefully I have done.
Sorry, thank you very much.
No, you're welcome. I'm aware that I've come to the end of my little half-hour window, but if anyone had a brief question, I'm happy to field them or send them later.